the next speaker, okay, will be Dr. Santalla Hernandez from Granada. Yeah? And the topic is radiofrequency technology in the myoma treatment. Please.
Thank you very much for the invitation. I'm glad to share this time with you. Let's start. That's my conflict of interest. I've been a trainee for transvaginal fiber radiofrequency ablation since 2018. So first we're going to see what is radiofrequency ablation. Radiofrequency generates heat in the fiber. It raises tissue temperature up to 19 degrees, causing a coagulative necrosis in the tissue, reducing fibrous volume and its related symptoms. There are several ways to apply radiofrequency in the fiber. The first one is through laparoscopic access. The radiofrequency needle is inserted through a trocar and is placed in the sac center of the fiber. A type of membrane is deployed, and in only one shot, the whole fiber is ablated. This procedure is similar to what is done in transcervical radiofrequency ablation. A similar device similar to an hysteroscopy is introduced to cervical canal after cervical dilation and is placed again in the sac center of the fiber. This membrane is deployed, and in only one shot, the whole fiber is ablated. Another way is through vaginal way, through direct fornix. Under ultrasound guidance, we place the needle inside the fiber, and we perform several shots of ablation of 1 centimeter of diameter spheres of ablation, and we move along the fiber to adapt to the sac shape of the fiber. Although there are many studies published regarding its efficacy, I only bring one because we don't have so much time. This is a meta-analysis published in 2019. It includes 32 studies with more than 1,000 patients and includes studies regarding laparoscopic radiofrequency, vaginal radiofrequency, and transcervical radiofrequency. As you can see, after a year, there is a significant improvement in all quality of life scales, reducing severity symptom scales, with a mean volume reduction of 66%. Nearly 5% of the patients need surgery before a year to control the symptoms. As you will see, these results are almost the same in all the published papers about radiofrequency. This slide includes all the information regarding obstetric outcomes after radiofrequency ablation. Although there are not many cases so far, no negative or adverse obstetric events have been described. This data led the ACO to include radiofrequency in its practice bulletin of management of symptomatic uterine leiomyomas in 2022, and it considers laparoscopic radiofrequency ablation as a useful technique to treat women, fibrotic women which want to preserve their uterus. Now I'm going to focus on transvaginal radiofrequency ablation because it's the technique that I have my experience. This is the actual situation of transvaginal radiofrequency in Spain. Today there are more than 90 public and private centers performing this technique, and more than 100 of our colleagues are offering these techniques. On the right side of the slide, you can see the evolution of this technique in the past 5 years, where the number of centers practicing this technique has multiplied by 3. Last year, more than 1,000 procedures have been performed in Spain. All this activity has allowed us to build medical evidence around transvaginal radiofrequency. Several articles have been published, one from Dr. Ray from Seville and many others from our group. And the main important one is the one on the top, at the bottom of the slide on the right side, is a multi-center study that we are running now with 12 centers and more than 500 patients. All these articles report almost the same results, with a mean volume reduction of 80% after a year, with a complete disappearance in 50% of the cases, and an improvement in all symptoms with a mean menstrual bleeding reduction of 50%. Complication rates are about 6%. These results are quite similar to published by other techniques regarding fibro treatment, like laparoscopy or uterine artery embolization. About the multi-center study, I only want to highlight 3 things. The first one is to show you the type of fibroids that we are treating with transvaginal radiofrequency ablation. As you can see, there are mainly type 2, type 3, type 2-5 figures, those fibroids that are not easy to treat with other surgical techniques. The second one is about tolerance, procedure tolerance. As you can see, we got good results on pain scales. The mean duration of analgesic use at home are 3 days, and nearly 50% of the patients are back to work 48 hours after the procedure. 80% of the patients are back to work a week after the procedure. And the third important data to me is that we didn't identify any difference either on clinical results or volume reduction between the 12 medical centers participating. These are the indication, or rather recommendation, of transvaginal radiofrequency ablation. It can be performed nearly in all types of fibroids, but I think the best indications are those fibroids that are not easy, and I remark easily treatable by hysteroscopy. I'm thinking of type 0, type 1 fibroids over 5 centimeters, type 2, type 3 fibroids, 2-5 fibroids. This procedure can be performed in all ages, and we have already identified some factors predictive of response, like age, fibroid initial size, and vascularization. These are the main complications reported regarding this technique. The worst complication is the possibility of developing an extrauterine thermal injury. Luckily, this is very infrequent. Another complication is the possibility of triggering a systemic inflammatory response, and is frequent in intracavitary fibroids. The vaginal expulsion of fibroid remains that we should warn the patients. This is the material we need to perform the procedure. On the top on the left, you can see the radiofrequency generator. On the right, below the radiofrequency generator, there is a cooling pump that cools all the circuit. And the really important part of the equipment is the needle. The needle has, at the end of the needle, is the active part. When we operate the system, a sphere of 1 centimeter of ablation is performed. The transvaginal access is a standard vaginal access, exactly the same we use in oocyte recovery in IVF. It is a completely ambulatory procedure, and patients are discharged home 2 hours after the procedure. This is more or less the technique. We place the needle inside the fibroid, and we perform several spheres of 1 centimeter of ablation along the middle, along the fibroid. We're going to see this video. Let's see if it runs. Yes. As you can see, this is a type 2 fibroid. It's not an easy fibroid to treat by hysteroscopy. We place the needle into the fibroid, and we perform those spheres of 1 centimeter of diameter of ablation. Once the first sphere is performed, we move the needle to perform another sphere of 1 centimeter of ablation. The main difference with the other techniques regarding radiofrequency is, as I said, that we move along the fibroid to treat the fibroid. This allows us to adapt to the exact shape of the fibroid and decide which areas we want to treat and which areas we do not want to treat, maybe because they are too risky. As you can see, the fibroid is being ablated. It's important that the own needle detects when the tissue is already ablated, because it detects the change in tissue impedance and automatically decreases the power to avoid carbonization or spreading the ablation area beyond what is desired. So when we operate the system, the power raises, we perform the ablation, and it automatically decreases the power when the ablation is finished. You see how all the fibroid turns white on the ultrasound screen as the fibroid is ablated. We consider that the procedure is finished when we have ablated 80% of fibroid tissue. So, after all these years performing this technique, this is our main conclusion about the technique. We believe that radiofrequency ablation is an effective, reproducible technique with minimal complications. It is especially indicated, I think, in fibroid type 2, type 3, and 2 type fibroids with no more than 6 centimeters of diameter. You can combine treatment either with medical treatment or hysteroscopy. It's quite frequent that once we perform a radiofrequency in a big fibroid and it has reduced its volume, to perform an office hysteroscopy to get a complete resection of the fibroid. Really, there are two groups of patients that can benefit from this treatment. One of these group of patients are patients over 40 years old with a heavy menstrual bleeding problem related to fibroid. In this group of patients, we know that the techniques works really well with an important reduction of its volume, and we are talking about 90% volume reduction and a good control symptoms. The other group of patients are patients under 40-year-old with a sterility or fertility problem related to fibroid. In this group of patients, we know that the volume reduction is a bit lower, around 60%, 65% of volume reduction. And we do know that after 2 years after the procedure, there is 15% of the cases in which the fibroid starts growing again. So the aim of treatment in this group of patients is with a minimal invasive technique with minimal complication to reduce as much as possible fibroid to get the best possible uterine cavity to approach pregnancy. Just to finish, I wanted to show you some photos of Granada, where I live, where we perform the courses. And to continue with the theme about Game of Thrones of this meeting, I must say that I'm not sure if radiofrequency is yet ready to sit on the same table as ultrasound or hysteroscopy, but I believe it is a quite good-looking alternative that is coming to the Three Kingdoms to stay. Thank you very much.